preoperative aortic annulus sizing non-invasive imaging techniques versus direct surgical side.
Preoperative aortic annulus sizing, non-invasive imaging techniques versus surgical sizing. Transcaster aortic valve implantation has emerged as an alternative and safer option rather than the conventional aortic valve replacement surgeries, especially in elderly patients with severe aortic stenosis. It has a better outcome. Detecting the exact measurement of the aortic annulus is considered a pivotal step in performing successful TAVI, as it is a closed heart technique lacking the ability of viewing and measuring the aortic valve directly intraoperative. Multiple non-invasive methods are used nowadays for preoperative aortic annulus measurements, with no consensus regarding the best modality. Transthoracic echo, transesophageal echo, multi-slice CT, and cardiac MRI. Transesophageal and transthoracic echo both have their own drawbacks related mainly to both the observer as well as patient-built variability. Multi-slice CT is a more satisfying preoperative imaging technique for assessment of aortic annulus size. It allows 3D analysis of the aortic valve and better assessment of calcified aortic valve. CMR in general has growing role in assessment of valvular heart disease. However, no sufficient studies have addressed the correlation of annular dimensions by CMR to direct intraoperative measurements. Aim of this work is to compare the size of the aortic annulus measured by non-invasive methods, 2D transthoracic echo, multi-slice CT, and cardiac MRI, compared to the direct intraoperative annulus sizing in patients undergoing open aortic valve replacement surgeries. Patients scheduled for aortic valve replacement was referred to us with their full echocardiographic data. Only patients with sinus rhythm were included, while patients with frequent ventricular arrhythmias or acute ischemic cardiac conditions, patients with bad general conditions, patients with contraindication to CT or MRI were excluded. After the aortic valve surgery is obtained, data from intraoperative data was obtained, analyzed, and then compared with the imaging data. For CT measurements, reconstructed double oblique axial images were done along the plane of the aortic annulus. Aortic annulus measurements was done during systole. CT maximum is the maximum diameter, and the minimum diameter were manually measured through the center of the aortic annulus. The mean of the two measurements is the CT mean. And then we trace the aortic valve to obtain the aortic valve area, and from the area we calculate the CT effective diameter from the equation 2 times square root circumferential area divided pi. For MRI, of course, the same can be done if we obtain the parallel images on the aortic valve, and we added only the aortic dimensions in systole and in diastole from the LVOT view. Intraoperatively, the aortic annulus size was assessed after resection of the valve cusps, decalcification of the annulus. Then sequential aortic valve prosthetic sizers were inserted in the aortic annulus until the definite size is selected based on the sizer that barely passed through the annulus. After metric sizes, the appropriate size of the valve prosthesis was implanted. Correlation of the aortic annulus diameter in different imaging modalities versus the direct intraoperative sizes revealed that better correlation was obtained when using the CT effective diameter and then the CT mean diameter. The CT effective diameter also proved to have the highest agreement compared to intraoperative sizing on using the Blunt-Altman analysis. This is an example of a male patient, 36 years old, skeletal phenotype features of Marfan syndrome with history of aortic regurg indicated for aortic valve replacement surgery. Echo revealed tricuspid aortic valve with severe aortic regurg. This is the minimum and maximum CT diameters. This is the aortic valve area that we will use it to obtain the CT effective diameter. This is the MRI dimensions in systole and in diastole. In this individual patient, the CT effective diameter was 25.6, and actually the prosthetic size was 25 millimeter. So to conclude, the effective CT diameter is the most acceptable non-invasive preoperative measurement technique for aortic annulus sizing prior to aortic valve replacement. It shows the best agreement with the surgical intraoperative direct sizing. And thank you.
Thank you, Dr. Best, the presentation. If anybody has questions to